Good evening. Welcome to our small renal mass CUA guidelines update. We're so grateful that you've come to join us this evening. I'm particularly excited about this report, this session, because I happen to fall into that category and have for a number of years. So I'm always anxious to learn more about new discoveries, new choices, and what is going forward for people that are like me, being diagnosed with small renal masses and not too sure what's ahead of them. So I have Dr. Patrick Richard. He is a longtime friend and supporter of Kidney Cancer Canada. We're so grateful that he's here with us this evening. Dr. Richard actually has been involved with Kidney Cancer Canada for several years, many years, and actually one of his first research projects, I think, was with us, Dr. Richard. So we're grateful that he's here with us this evening, and we'll share the CUA guidelines. I just wanted to let you know I learn something every time these webinars come, and I was doing a little research today, and I cannot believe the number of research papers, Dr. Richard, that you have authored. You are quite an expert on the small renal masses, with a couple of other doctors I noticed were on the papers as well. So it's bonus for us that you're here to share this information with us. So I'll let you take it away. Thank you so much for being here. And if you don't mind, we'll have questions from the audience at the end. And audience, if you would like to check in the chat, we have links to the actual guidelines that you can check into later, okay? So welcome and enjoy. Thank you.
Thank you very much, Christine. Hi, everyone. Thank you for the invitation. I'm really glad to be here. I think Kidney Cancer Canada has always been very supportive of my work and supportive of I guess, the patient with kidney cancer across Canada. So I'm glad to share some of my experience and glad to share the updated guidelines that we just published a few months back. Let me just share my screen. So just as an intro, Christine did mention I'm a urologist, a uro-oncologist. I trained under the guidance of Dr. Finelli and Dr. Jewett in Toronto. And that's what brought my interest towards kidney cancer, which is my main area of expertise and research nowadays. I'm in Sherbrooke, Quebec, which is a city about an hour and a half from Montreal, for those who don't know, which is very lovely this time of year, especially. So today, I'm glad to present the most recent update, the CUA update on the management of small renal mass. This was done in collaboration with a number of urologists, radio-oncologists, and I'm especially glad to say that this was done in partnership with two patient advocates, Christine Collins and Andrew Weller, both members of KCC, as you're probably aware. I think both our patient advocate had a big say on our different recommendation. I think this was one of the first COA guidelines where we actually included the patient voice in our different recommendation. So first off, I think what we need to discuss is what is a small renal mass, what is considered a small renal mass. So a small renal mass is a solid kidney lesion, which is usually less than 4 centimeters in size. These can come in different size and shape, but basically these are, for the vast majority, a malignant tumor, although a significant proportion of these tumors or lesions will be benign. So why is there a need for a specific guidelines on small renal mass? Well, different studies, mostly from the US, but also from Canada, has shown that over the last 2 decades or so, there's a drastic increase in the incidence of renal lesion being detected. And this is mostly due to the fact that we're doing more and more abdominal imaging for whatever reason, and more kidney lesions are being picked up. What we've also noticed is that there's a direct correlation between having a tumor diagnosed, having a lesion, sorry, not necessarily a malignant tumor, but having a lesion diagnosed on imaging and having subsequent renal procedures done, most of the time either a partial nephrectomy or a radical nephrectomy, and we'll get back to that a bit later. However, despite the fact that we're diagnosing more and more patients, we're operating on more and more patients, what we've noticed is that, as you can see from the blue line, the mortality rate of kidney cancer has not really improved over the last decades or so. So although we're treating more patients, diagnosing more patients, we haven't made a lot of difference in terms of mortality. So either our treatment is not good, which we know that's not the case, or more likely that we're diagnosing and treating a lot of lesions that are probably not likely to cause any harm, at least on the short or mid-term, to most of these patients. So why is that? Well, first, about half of all renal masses that are now being diagnosed are small renal masses, so lesion less than 4 centimeters. As I alluded to, not all of these lesions are cancer. About 10 to 30% of all these lesions will be benign, so of no risk whatsoever for the patient. And most importantly, even if these lesions are malignant, even if they are cancer, they portend an excellent prognosis with a low likelihood of recurrence and a low likelihood of causing death on the long term. Most of these lesions are indolent. I'm talking about small renal mass, right? Again, so most of the lesions are indolent. About 70 to 90% will be low grade with low metastatic potential. We're talking about a risk of about 1 to 2% at 5 years. And most importantly, most of these lesions are slow growing, and they grow an average of about 1 to 3 millimeters a year. So what we've known, or what we know about kidney cancer and small renal mass, is that we don't necessarily need to treat all of these lesions, and that there are several well-accepted treatment strategies to manage these lesions, but the best one is yet to be, I guess, identified, and remains debated. So what we all agree as an expert and as doctors is that when there's multiple choice of treatment, I think the treatment should be personalized using shared decision making after proper counseling and while taking into account tumor characteristic, patient factors, and I think most importantly, patient values and preference. That being said, we did come up with recommendation on how to manage small renal masses. We made recommendation based on the GRADE framework, which is a well-accepted framework to come up with guidelines and recommendation. We came up with either a strong or a conditional recommendation, which a strong recommendation basically means that we believe that the vast majority of patients across Canada should be managed this way. A conditional recommendation is that we believe that most patients should be managed this way, but not necessarily all of them. When we had insufficient evidence to really come up or formulate a good recommendation, we reported the additional information as clinical principle or expert opinion. So first off, we divided the guidelines in different sections. Just as a FYI, you'll have access to the PDF of these guidelines in both French and English in the chat if you're interested. So first thing is what kind of how are we imaging these lesions? Is an ultrasound enough? Well, I think the ultrasound is good in order to assess for the size of the lesion, but it's not good enough to really be able to identify the characteristics of the lesion. So what I like to say to my patient is that an ultrasound is sort of like using a high definition TV, while a CT scan is really a 4K television. So I think that high definition does the job. I think but I think for the first image, I think it's important to have a better imaging, either a CT scan or an MRI, to really be able to identify the lesion better, characterize it better, and especially make sure, although uncommon, that there's not the presence of any metastases or a tumor thrombus that could be associated with these small renal masses. But again, this is quite rare. It's also important to image the chest. There's some lung metastases that can appear with a small renal mass. This is quite uncommon. We're talking about a risk of 1 to 2% at diagnosis, but this is quite rare and uncommon. We did debate on the fact that whether we should do a chest CT at diagnosis, but because this is a more costly exam and leads to additional non-necessary investigation for different reasons, we opted to recommend a chest X-ray because we thought it was easy for a patient and cost-effective as an imaging method to rule out pulmonary metastases. All right, limitation of the exam, the CT scan, unfortunately. So I just put up 2 CAT scan. This is the left kidney on either side. These are 2 patients. One patient with a kidney lesion, which is about 3 centimeter in posterior, and another one that has a 3 centimeter lesion, which is anterior. Here, very difficult on imaging to say whether one of these lesions is benign, one of these lesions is malignant. Unfortunately, that's the limitation that we deal with in clinic. It's very difficult just by looking at the images to figure out whether a lesion is benign and malignant. And currently, the only way to identify whether a small renal mass is benign or malignant prior to treatment, obviously, is to biopsy one of these lesions. The way we do this renal mass biopsy is usually under ultrasound or CT scan guidance, and we insert a small needle through your back in order to get a sample of the tumor. Usually we'll get 3 or 4 cores of biopsy in order to maximize the diagnostic yield of a renal mass biopsy. So what the guidelines says is that, and this is an expert opinion, is that small renal mass patient with small renal mass should be offered a renal biopsy when the result of this biopsy may alter management. Obviously, not every patient should have a biopsy, but at least a renal mass biopsy should be discussed with most of these patients, if not all of these patients. However, it is important to inform the patient of its risk benefit. These are if you believe in biopsy as a physician, I think there's a lot of role for a renal mass biopsy, but they're not without harm. So first thing the patient should be aware is that they're not perfect. We have about a 90% diagnostic yield, but this means that about 10% of patients will have a non-diagnostic biopsy, which basically means that we're not better off with the biopsy. We won't know what this lesion is in about 10% of cases. There's also the possibility of false negative rate, meaning that we identify a lesion on biopsy as being benign, but in fact, if we would operate or remove this lesion would be a malignant tumor because of the uncertainty or difficulty in differentiating certain histology or certain type of kidney cancer or kidney lesion. We think that this is pretty rare. We're talking about less than 5%, but I think that's something that patients should be made aware of. Finally, the last thing that should be discussed with patient is although their complications are rare, they are not zero. We're talking about a significant complication in about 1% of cases, where rare complication of tumor seeding, meaning that we can actually spread the tumor a bit outside of the kidney by doing a biopsy, but we think that this rate or this event is quite rare, about 1 out of 1,000, 1 about 10,000 events. So pretty trivial, but something that still should be discussed with patients. Just as an FYI, these lesions, these are 2 of my patients. Both of these patients were biopsied and both ended up having a benign tumor, which is pretty difficult to ascertain on these imaging whether these lesions are malignant or not. There's a bunch of studies that looked at the benefit and the risk of renal mass biopsy. Most of these studies comes from Canada. I think this is one of our major contribution to the field of kidney cancer. And most of these studies does support the role of renal mass biopsy and does demonstrate that by doing a renal mass biopsy, we do decrease the number of patients that undergoes unnecessary interventions. If you're interested, there's a whole guidelines or consensus paper just on the role of renal mass biopsy. At the very least, I think what these guidelines does support is that not all patients should necessarily have a biopsy, but all physicians should at least discuss the potential role for renal mass biopsies in their patient. And after informed decision should be made on whether to proceed or not with renal mass biopsy. Another thing that we highlighted and is often forgotten is that there's a role for genetic counseling when diagnosed with a small renal mass or a renal tumor. There's different characteristics that physicians should be made aware of that renders patient a bit, and their family, I should say, a bit more at risk of having subsequent RCC or subsequent renal cell carcinoma. And in table 1, we discussed a different option. Basically, the easy ones to remember is that if you do have bilateral or several kidney tumors, and if you're young or have a relative that has a history of renal tumor, your physician or you should probably discuss genetic counseling with your physician and discuss the pros and cons of going ahead with a genetic consultation. All right, so now let's talk about, I think, the important or interesting part of the guidelines, which basically what we all want to know is the management of small renal mass. How should we manage these lesions? So there's several well-accepted strategies to manage small renal masses. The most obvious one or the most commonly done procedure is a surgery or a partial versus a radical nephrectomy. A partial nephrectomy is a procedure where we remove just the lump, just part of the kidney, the diseased part of the kidney, and and the good kidney remains in place. A radical nephrectomy is an easier procedure to do for a urologist, and we would remove the whole kidney at this time, and we'll discuss the pros and cons of each approach a bit later. Other options are thermal ablation. These are usually done by inserting needle through the skin under local anesthesia and with a bit of sedation. There's two well-accepted strategies in Canada, although several others exist. The most common ones are either cryoablation, where we freeze the tumor in order to kill it, or the RFA, which is a radiofrequency ablation, where a tin lead is inserted and this lead will burn the tumor in order to kill it. Last option is active surveillance. Like I've alluded to, a lot of these lesions are either benign or have a low risk of metastatic potential. And the role of active surveillance is to delay treatment until there's evidence of local progression on imaging, at which time the patient would be offered a treatment. We'll discuss the pros and cons of each of these interventions in a few minutes. So how to choose for a patient, how to choose for a physician. Well, it's not always an easy decision. I think it's a decision that needs to be discussed with our patient. You have to balance cancer control, getting rid of the cancer, which is probably one of the most important aspect of management of kidney cancer, but also we have to factor in the morbidity of the patient, the complication associated with our different treatments, and also trying to preserve the kidney function, which is important because losing kidney function has been associated with renal insufficiency, which has been associated with increased risk of needing hospitalization, increased risk of having cardiac event, and subsequent death, unfortunately. So as I mentioned earlier, I think although there's several well-accepted strategies, not one has been shown to be better than the other. And what the guidelines panel just wanted to emphasize is that the choice of treatment should really be personalized, really should be individualized according to several factors. The most important one are patient factors and patient values and preference. But we should also take into account the age, the comorbidity of the patient, his surgical, medical history, while factoring in, is this a very small tumor? Is this a larger force intermediate lesion? Is this an easy surgery, a more complicated surgery because the kidney is really, the tumor, sorry, is really localized inside of the kidney, or is it more of a, we can just scoop it like an ice cream and just take it out? Last thing I think that physician should be and patient, unfortunately, need to factor in is what type of access do they have in their at their center? Can you do can their physician or urologist do a partial nephrectomy? Do they have access to thermal ablation, or do they have to drive 200 kilometers to have access to care? I think these are all uh, characteristics that would influence a patient decision towards which treatment a patient would decide. Fortunately, it's a bit of a complex decision for both patient and physician, and we do have decision aid. We do have tools available in both French and English in order to guide a patient towards their decision. This is the first decision aid, and I believe only decision aid available. This was supported by Kidney Cancer Canada, so it's something really to be proud of. And this was designed by Luc Lavallée and his team in Ottawa, freely available. I've been using it in clinic in both French and English, and I think something that more and more urologists in the near future are going to use. And I think Kidney Cancer Canada is already doing a good job in promoting this decision aid. I think it's an important tool in order to help us make the decision that is more in line with the patient values and preference more than anything else. All right, so should all small renal masses be treated? The answer is definitely no. There's some patient, especially the older patient, the patient with more comorbidities, that should not be treated. This was a strong recommendation. The preferred strategies for these patients should be observation. Why is that? Well, this is a graphic or a table that I took out from one of the paper that was recently published, where they tried to they looked at the probability for a patient of dying from kidney cancer versus the probability of a patient of dying from other causes. This example here is for a 80-year-old patient with some comorbidity and a 3-centimeter renal mass. What this study demonstrated is that for these patients, the risk of dying after a procedure, either after radical nephrectomy, a partial nephrectomy, thermal ablation, or active surveillance, risk of dying from his renal cancer is very low. We're talking about 1 to 2%. But the risk of this patient of dying from other causes, cardiac event, a stroke, and whatnot, is way higher, about 17% for this patient. What does this mean is that this patient, this 80-year-old gentleman, is way more likely to die from other causes than from dying from his kidney cancer. And by treating his kidney cancer, we're just probably adding harm and adding comorbidity to his quality of life, as opposed to just leaving this lesion alone. And this is basically what this first statement in the guidelines says, is that if a patient has significant comorbidities or a limited life expectancy, this patient should be observed, as a treatment will have more detrimental impact on his life expectancy than anything else. All right, for the next step, the next thing we've done is we've tried to categorize the treatment according to tumor size. We divided tumors we divided patient for with lesions less than 2 centimeter versus 2 to 4 centimeter in trying to make the guidelines a bit easier to understand. This is not a perfect way of characterizing small renal mass and is maybe oversimplifying things, but we thought that this was the best way, the panel thought that this was the best way to characterize small renal mass, best or easiest way to characterize small renal mass. So what we've done is that for 2 centimeter, we looked at the different evidence, and basically what we've come up as a recommendation, which is a conditional recommendation, meaning that we think that most patients should be managed with this way, is that for most patients with a 2 centimeter or less tumor, active surveillance should be the preferred strategy. Now, this might be a bit controversial as guidelines from other associations does not necessarily recommend active surveillance as the preferred strategy, but we weighted the pros and cons of doing an intervention versus the pros and cons of doing active surveillance. So why did we choose to recommend active surveillance as the preferred strategy? Well, like I discussed, these tumors are slow growing, about 1 to 3 millimeter a year. They have a low probability of having an aggressive histology, low probability of developing a metastatic lesion at 5 years, about 1 to 2%. And most importantly, there's a numerous studies that have shown that at least on short and midterm, the cancer-specific survival, meaning your chance of surviving kidney cancer, is pretty much similar between active surveillance, surgery, and terminal ablation. So I'm just presenting very, very quickly 2 studies. The first one is a study close to my heart because it was designed by Dr. Jewett and Dr. Finelli in Toronto. And this was the first study that actually demonstrated the safety or the oncological safety of active surveillance. This was a multi-center Canadian study, about 200 patients, which this study shows is that it was a low risk of metastases. Yes, this was early, about 1.1% of metastatic disease at 2 years. But when we look back at these patients, unfortunately, most of these patients were already metastatic at diagnosis. What we've also noticed is that about 12% of these patients required surgery or an intervention over time. But the cancer-specific survival, meaning your chances of being cured, even if you had delayed intervention, was similar to the patient that were managed with upfront treatment. The next study I just wanted to briefly mention is a lot of urologists, physicians, or even patient will be comfortable with active surveillance, especially for elderly patients. But we have good data, good studies, especially from the US, which has demonstrated that even for younger patients, this was a study that included only patients less than 60 years old. This study has shown that at 7 years, regardless of what you chose as an option, either active surveillance or surgery, there's no difference in overall survival, and there's no death due to kidney cancer at 7 years. So no different whatsoever in terms of what you chose as your initial option, as your initial treatment option. Now, is it because you chose active surveillance as your initial treatment that you'll necessarily remain on active surveillance for the rest of your life? Obviously, no. This risk is higher if you're younger, but this study shown that the chance of, or the risk, I should say, I guess, of needed an intervention while on active surveillance is about 30%. Importantly, this study has shown that this risk was quite lower if you have a small tumor less than 2 versus a bigger tumor. We're talking about 15% for a smaller than 2 centimeter tumor. About 1/3 of patients with a 2 to 4 centimeter tumor will eventually require an intervention. So I think if you're on active surveillance, currently on active surveillance or considering active surveillance as an option for you, what you have to remember that is quite a safe option, but there's about a 30% chance that eventually you'll require an intervention. that this risk is higher if you have a 2 to 4 centimeter tumor rather than a less than 2 centimeter tumor. However, despite active surveillance being the preferred strategy, I think it's important to say that even if this is a preferred strategy, your urologist should at the very least discuss the other option, be it a surgery or thermal ablation, and ensure that the patient is fully informed in terms of treatment option and that they make the decision according to their own values and preference and not according to the pressure of the physician being inclined more towards one option rather than the other. The next was for 2 to 4 centimeter tumor, and this was a bit of a more an active conversation between the members of the panel. Should we recommend treatment or should we recommend active surveillance? Basically, what we came up as a recommendation is that both active surveillance and definitive treatment, partial nephrectomy or thermal ablation, were suggested as management option. And unfortunately, we were unable to achieve a consensus on one strategy over the other. What we came up as a statement is that active surveillance, like partial nephrectomy, like thermal ablation, should be offered as an option to patient with a 2 to 4 centimeter tumor. But about 90% of the panel members felt that definitive treatment should be considered as the option of choice. However, because we were unable to achieve a consensus, the recommendation is that active surveillance should be considered on par with definitive treatment as management option, and that not one should be favored over the other. Now, I've alluded to, if you choose active surveillance, there's about a 30% chance of eventually requiring a treatment. We did come up with recommendation in terms of when should a treatment be offered to patient. Basically, there's a couple of reasons why a treatment should be offered to patient while in active surveillance. The most obvious one is a patient changes his mind or her mind and wants to have an intervention, at which time either partial nephrectomy or thermal ablation should be offered. The other time would be when the benefit of treatment no longer outweigh the risk of an intervention, meaning the patient is getting older, is sicker, and the benefit of treating the patient, a bit like the 80-year-old gentleman that I presented earlier, the benefit of treatment is now not as strong as the risk of this intervention or the risk of dying from other causes such as a cardiac event. The last reason would be when the oncological risk increases, and there's a couple of reasons why this risk would increase. One is the growth of a tumor. The threshold, usually the well-accepted threshold to recommend a treatment, is when a tumor grows over 4 centimeters. The other reason would be when a tumor grows quickly, and the definition of what is a quick growth would be more than 5 millimeters in a year based on a few consecutive imaging, usually a CAT scan. And the other one, which is fortunately very rare, would be a progression to a metastatic state, at which time we would offer not a surgery, but a systemic treatment in order to try to control the disease. All right, now, give me 2 seconds. Now, if a patient considers definitive treatment over active surveillance, should this patient have a surgery? Should this patient have thermal ablation? Well, we considered all the evidence, and what we recommended is that both options should be considered as equal option, and both options should be discussed with patient. Here, the observation studies, the studies out there, or the literature, does seem to suggest that thermal ablation, either cryoablation, we freeze the tumor, or radiofrequency ablation, we burn the tumor, yields similar cancer control compared to surgery. One caveat to this is that there's a higher uncertainty around the data supporting the benefit of thermal ablation when compared to the benefit of surgery. There's more paper, more studies on supporting surgery, a bit less on thermal ablation, and the patient that has undergone thermal ablation are a bit more selected patient than the patient that has undergone surgery. So this uncertainty, I think, is important to be discussed with patient, because patients that are less likely to want to take a risk based on the evidence should be more inclined to have a surgery, while yes. So basically, patients should at least be made aware that although a thermal ablation and surgery are considered equal, there's a bit more uncertainty on the evidence supporting thermal ablation than the evidence supporting surgery. But again, both should be considered equal. Now, as for surgery, if a patient prefers or wants to undergo surgery, should this patient have a partial or radical nephrectomy? There's pros and cons of each option. Obviously, if you remove only part of the kidney as opposed to the whole kidney, there's a better preservation of the kidney function. As I mentioned, we think there's a correlation between a better kidney function and the lower likelihood of needing hospitalization, having cardiac event, and a subsequent death. So as a urologist, as a physician, we believe that preserving kidney function is important. There's also studies comparing partial and radical nephrectomy, and only removing the tumor seems to be as good as removing the whole kidney in terms of cancer control. However, if you're cutting through the kidney, obviously it's a bit of a more complex surgery, meaning there's a higher risk of complication than if you're just removing the whole kidney, which is a simpler, quicker procedure. So when we consider the pros and cons of a partial versus a radical, I think given the overwhelming evidence supporting partial nephrectomy, we came up with a strong recommendation, which means that the vast majority of patients with small renal masses that chooses a surgery should be managed with a partial nephrectomy as opposed to a radical nephrectomy. Why? Well, as I mentioned, there's an overwhelming number of studies demonstrating that partial is equivalent in terms of cancer control compared to radical nephrectomy. There's the importance of preserving kidney function. And then most importantly, although cutting the kidney is a surgery that has a more risk or higher risk of complication for the patient, most of these partial nephrectomy can be done safely and with minimal increased harms compared to a radical nephrectomy. That being said, should a partial nephrectomy be done in all patients, in every patient? The obvious answer is no. I think there's still a role for certain patients to have a radical nephrectomy. Patient which a partial nephrectomy would be complicated, even in expert hands, should probably be offered a radical nephrectomy over a partial nephrectomy, or patients who are unwilling to accept the higher risk of partial nephrectomy, especially for a more complex tumor or the higher risk of thermal ablation as opposed to radical. I think these patients should be offered a radical nephrectomy, but these should be outliers. These should be a minority of patients, as most patients undergoing surgery should have a partial nephrectomy. I think urologists should consider a partial, and if they're not comfortable doing a partial nephrectomy on their own, they should refer these patients to an outside institution, given the importance of preserving the kidney function. This was a pretty easy recommendation. but when feasible, partial surgery should be done with a minimally invasive approach, meaning either a laparoscopic approach or a robotic approach, as opposed to the more traditional open approach. Several studies have shown that there's a lower morbidity of a minimally invasive surgery compared to an open approach. There's a smaller scar. As you can see, this is a scar made after a radical nephrectomy, as opposed to the small scars made after a robotic partial nephrectomy. The scar is smaller, the recovery is quicker, lower risk of bleeding, lower risk of having a complication, and quicker recovery, and so lower impact on the quality of life. Obviously, a minimally invasive surgery is not always possible, and the panel believed that having a open partial was better than having a radical nephrectomy being done minimally invasive, using a minimally invasive approach, as long as the patient was willing to accept the higher morbidity of the open approach. So now that we've discussed management option, the next thing that we've discussed in the guidelines was follow-up during active surveillance. We believe that given the lower costs and lower harms to patient, that these patients should be followed with an abdominal ultrasound and not a CAT scan or MRI, at least for most of these patients. And they should also have a chest X-ray. And these, in order to rule out metastases, the abdominal imaging and chest X-ray should be done until definitive treatments are no longer considered, meaning until patients are no longer considered for surgery or thermal ablation because of change in their medical condition. If a tumor growth is identified or suspected on ultrasound, because of the limitation of ultrasound, these patients should have a regular cross-sectional imaging, either a CT or an MRI, in order to better delineate the lesion and plan a treatment intervention. There was, as any guidelines, we're trying to make recommendation or guidance to urologists in terms of frequency of imaging. Unfortunately, the panel was unable to achieve a consensus as to the frequency of imaging, but what we believe to be safe was an imaging every 3 to 6 months of the kidney for the first year, and then every 6 to 12 months if the lesion remains stable. For the chest X-ray, there was, again, we were unable to achieve a consensus. The frequency of imaging varied from either if the tumor grows to every year, and there's no, these were expert opinions, and there's no consensus on the frequency again. What about after treatment? We'll just go quickly because there's a whole guidelines that was published back in 2018 on the management of patients that had a treatment for RCC or renal cell carcinoma. Basically, for these patients, similar to active surveillance, they should have a routine chest X-ray to rule out the presence of a lung metastases, as well as an abdominal imaging, either a CAT scan, an MRI, or an ultrasound to rule out the presence of a recurrence. If the patient has a lower kidney function, less than 45 millimeter per minute after a surgery, these patients should be referred to a nephrologist or at least a general practitioner in order to make sure that we are optimizing the kidney function and thus decreasing the chance of them having issues due to their kidney function, needing a hospitalization, cardiac event, etc., which has been linked to a lower kidney function. The timing of imaging after treatment is something debated, and that varies according to whether you read the CUA guidelines, the American guidelines, or European guidelines. But what the 2018 group tried to do is to tailor the imaging towards the risk of having a recurrence. the risk of recurrence after a partial nephrectomy or terminal ablation is quite low, especially after a partial nephrectomy. So what the group recommended is that at least for the 5 years after surgery, they should have an imaging at 2 and 5 years, and they should have a routine chest x-ray every year to rule out the presence of metastases. If the patient had a partial terminal ablation for the first year after treatment, it should be imaged a bit more frequently just to make sure that there's not either a complete ablation of the tumor or a early recurrence of the kidney tumor. In summary, I hope I convinced you that unfortunately, there's more and more patients being diagnosed with a small renal mass, and that if we're treating all of these lesions with upfront definitive treatment, either surgery or terminal ablation, that we're over-treating a lot of these lesions. These lesions will be benign in a significant proportion, about 30% of them, and especially if malignant, they have low risk of metastatic potential, with a 5-year risk of metastases of about 1 to 2%. One way of triaging these patients or decreasing the risk of doing an unnecessary intervention is to do a renal biopsy. And then these guidelines do recommend that at least a biopsy should be discussed with most patients before discussing the different treatment options available. Either active surveillance surgery, be it partial or radical or terminal ablation, does yield similar oncological outcome, and there's an importance for shared decision making here. There's a decision aid that can help patient make the decision, and we believe, as the expert on this guideline, that most of the urologists should be using this decision aid in order to guide their patient. Active surveillance as the initial management strategy is definitely safe and should be offered as the preferred approach for small renal masses, meaning lesion less than 2 centimeters. Definitive treatment, surgery or terminal ablation, leads to high cancer control regardless of the method choosing, but one have to remember that there's a higher uncertainty on the long-term efficacy of terminal ablation compared to surgery. Importantly, if you're going to have a surgery, one should probably favor partial nephrectomy over radical nephrectomy if possible, but there's still a role for a radical nephrectomy, especially if the tumor is complex, especially if the patient is willing to accept the risk of a radical over a partial nephrectomy, or if the patient is willing to accept the lower immediate harm, I should say, of a radical nephrectomy over a partial nephrectomy. And then if a patient is unwilling to, and then if a urologist is uncomfortable performing this partial nephrectomy, he or she should consider referring the patient to an expert center and not just defaulting to a radical nephrectomy because it's the easiest or easier procedure. Just the last thing I just wanted to discuss before we move on to the questions is that we did come up with an algorithm of management in order to try to summarize our different recommendations. I think that if you want to look at something on the guideline, I think this is probably the more bang to your buck, just to go over this algorithm, and in a glance, it does summarize the recommendation. Thank you. I'll stop sharing and perhaps we have some questions.
First, I'll say thank you so much, Patrick. That was excellent. And thank you for sharing in patient-friendly language. I know I have some questions. I'm going to invite all the attendees. If you have any questions, please type them in the chat and we will answer them for you. If we don't get to your question this evening, please send it. You can send it by email, info at kidneycancercanada.ca, and we will do our best to get the answer from Dr. Richard and send it to you so that you don't miss out on getting your question answered. Mona, would you like to join us? And we'll just monitor the chat. I do see that one question has come in, and I think it's from, sorry, I have my glasses on.
Well, the first one is from Deb.
Okay.
It's, will your group or the CUA be conducting research in the future to measure adherence to guidelines across Canada?
Oh, that's a tough one, Deb. Thank you.
So that's a tough question, tough one to answer. I think the issue with, although the guidelines, I think we've done a pretty good job to summarize the evidence and try to come up with something that makes sense. The issue with this guideline is based on a lot of limited evidence and I guess a lot of conditional recommendation based on limited level of evidence. So I think we're trying to slowly change the way urologists think towards maybe, so for sure, involving more the patient in the treatment decision rather than having a parent paternalistic way approach. But I don't think we can necessarily fault the urologist to not adhering to the guidelines just because of the limited evidence that the guidelines is based on. I think what the guidelines or what the evidence definitely showed while doing these guidelines that there's a dire need for better evidence, better study in order to guide urologists, guide patient towards finding the best available treatment for them.
Mm-hmm. Thank you. I have Chuck in the audience who has asked the typical size to treat for an ablation.
So usually most of the evidence on ablation is based on smaller tumors, less than 3 centimeter tumors. We do have evidence supporting using thermal ablation in bigger tumors, 3 to 4 centimeter. But what the evidence shown is that the recurrence rate is a bit higher for these larger lesions. It's not impossible to do, but the recurrence rate is a bit higher. So I think what the important thing is there's not a one-size-fits-all strategy. Patients should be made aware of the risk and benefits of each intervention. If a patient is willing to accept this higher risk with ablation as opposed to having a surgery, I definitely think that it's something to consider even in these larger lesions.
I have a question that ties into ablation, Dr. Richard, is if you do opt out to have ablation, cryoablation or RFA, and say there's some reoccurrence, down the road, is it possible to still have a partial or full nephrectomy?
So that's a good question. So the first thing that is definitely possible, if there's an incomplete ablation or a recurrence, you can have a second ablation being done to your kidney. That's the first thing to remember. It's easy to have another ablation done, low morbidity, low complication rate to have a second ablation done.
Okay.
Is a partial feasible after an ablation? Definitely. It's trickier, more difficult, but it's definitely possible. And likely that not every urologist will be comfortable doing a partial nephrectomy. So you do have a higher risk of being referred to an expert center if you have an ablation and a recurrence. But it's definitely possible and should not deter you to having an ablation just because you would prefer to have a partial later on as opposed to a radical nephrectomy. I don't think this should be a deterrent to having an ablation.
Okay, good. I had a couple more questions about that, but I'm going to defer to our audience. And I see Andrew said, and just Andrew popped out of there, when AS is no longer viable, how do you decide the next recommended option?
So another good question, and this is still through shared decision making. So I think if active surveillance is no longer an option, you should have a good conversation with your urologist. Not all tumors are amenable to a thermal ablation. Not all tumors are amenable to a partial nephrectomy. But all in large, I think you should have a good conversation with your urologist about the different treatment option, and even if you had immediate or if you had active surveillance up front, the same options are available to you afterwards, either thermal ablation or active surveillance. If thermal was an option when you were diagnosed with a kidney cancer or kidney mass, it's still an option now that you're considering stopping active surveillance.
Yeah, and I just want to let people know that, and I'm sure you'll concur, that radio frequency ablation or cryoablation has a lot to do with where your tumor is, and not everybody is a candidate. I mean, I wasn't able to consider that for my treatment, so it's not for everybody, but it is a great treatment if you can take part. I'll just finish.
Just something to add with regards to that is a bit like partial nephrectomy. Thermal ablation are being done by radiologists, and a bit like urologists, not all radiologists have the same degree of comfort with some of these more complex lesions. So it's not because your radiologist is not comfortable doing a thermal ablation that somebody else won't necessarily be comfortable. So that's also something to discuss with your physician.
Okay, quick answer while we're still on this subject. Is it available at all medical centers, or is it more of a specialized center that does the ablation?
So it is more of a specialized center, but a bit like everything, more and more community interventional radiologists are now doing this procedure. So I think we recognize this as a good option for patients and is being offered at more and more places.
Right. I'm so grateful for you to repeat a couple of times that if a preferred treatment for you is not available where your urologist is, or if your urologist isn't comfortable doing that particular surgery, that you should seek a second opinion at a different center. Thank you for saying that, because a lot of our patients are unsure, and it's their right, I think.
I think so, and I think a bit like when you're buying a car, you're likely going to go to a couple of dealerships before taking a decision. I think this is way more important than buying a car. So there's nothing wrong with shopping around, and there's no one size fits all strategy. The more urologist, the more physician you'll see, the better you'll understand your mass and your options available for you. I think it's definitely important and encourage, and there's nothing wrong with that. Definitely not.
I think we're a little bit afraid as patients that we're going to offend the doctors. But leading to that same question I have, and I'll give you 1 second. How can we ensure that my doctor understands these guidelines if they're not located near an expert center? Like, what confidence can they have in these urologists? And you can also answer the other question, sorry.
That's a very good question. I think that's the job of Kidney Cancer in Canada. That's the job of CUA, and I guess the job of the panel, the panel on these guidelines, to make sure that the outreach of the guidelines are throughout Canada and being disseminated properly. That's a good question. Basically, you cannot be sure. I think you need to discuss the option. You, as a patient, need to be aware of the different options available to you, and you need to make sure that you're comfortable with what your physician is telling you. And if you're not, don't be afraid to ask a second opinion.
Okay, good. Thank you for that reassurance. Mona, did you see a question that might need to be answered? They're all important questions, but
yeah, some of them are comments.
I have a good one. When does post-treatment surveillance end? Like, a lot of recommendations are 5 years. And, for a lot of treatments, surgery and so on, I'm a little nervous of that. What do you recommend?
Yeah, so that's a good question. I think what the 2018 guidelines recommend is that after 5 years, there's very little. So after 5 years, the chance of the cancer coming back decreases, right? It's low. But with the guidelines does not recommend to stop surveillance after 5 years. What it recommends is to have a conversation with your patient and tailor the follow-up accordingly. So maybe you don't have to do an abdominal imaging every year. You can maybe do it every 2 years. But I think what the guidelines does say is that you should continue to follow this patient for how long. I don't think we have good data that really tells us that it's definitely safe to stop after 10 years, X number of years. We don't know that. I think it's again a conversation that you need to have with your patient. As a urologist, you might feel comfortable referring your patient again to his family doc to have this follow-up. But I do think that you still need a follow-up after 5 years, but you probably can space out the follow-ups. You don't have to have them necessarily every year after 5 years.
Okay.
There is a question here, Christine.
Sure.
In the after treatment guidelines, frequency of scans, is it the same for the different types of cancer? Clear cell, papillary, chromophobia?
So the guidelines did not specify the difference. We know that there's some tumors that are a bit more at risk of there's some histology that are a bit more aggressive than others. But the guidelines does tailor the follow-up schedule according to, I guess, the size of the tumor or the stage of the tumor. But it does not tailor it according to histology. I think yes, the risk of recurrence is a bit higher with some histology, but not significantly so that the schedule should be altered because of the histology.
Okay, good. Maybe you can just make a quick comment. I know we're kind of at the end of the hour. A lot of concerns come through like in our coffee chats, and we're finding that the surveillance kind of routine is changing a little. And, where you once always had a CT scan, now it seems to be more often an ultrasound and a lung x-ray as compared to, a thoracic and abdominal CT. Is this safe? Is this the way that we're going? And can you just make a quick comment on that?
Yeah, so I think obviously having a CAT scan is likely better or is giving you more information than the ultrasound, but the CAT scan is also giving you more radiation and likely more harm. The ultrasound is for most patients good enough in order to have a good surveillance, a safe surveillance imaging with while avoiding the risk of having multiple CTs. So I think you need to have a conversation with your urologist. You might feel comfortable having a CAT scan for, let's say, the first year or so, but I think having if you're going to stay on surveillance for 5 years and you're going to have a CAT scan every 2 months, every 6 months, or every year, that's a lot of radiation for a patient. So I think if it's safe, if there's a good correlation between size on ultrasound and CAT scan, ultrasound is definitely the way to go in my mind, and that's what the panel also suggested.
Okay. Okay. Is that about it, Mona, or do we have another question?
Yeah, one more. Is SBRT a treatment for small renal masses?
So it's something that's being studied, something that we a bit left out from the guidelines because there's more and more data supporting the role of SBRT in the management of small renal mass, but these are small studies and definitely not ready for prime time yet, not ready for a national-wide recommendation in favor of some SBRT. I think that's an option that's available in some expert center, something that should be offered to patient when available, but it's something that should be available in a study and not outside the studies. I think we need more evidence supporting SBRT before offering it to all patients. But it's definitely something exciting, something that we're looking at, and maybe for the next iteration of the guidelines, the SBRT might be included, but I don't think it's ready for prime time yet.
Right. Well, just mention Chuck brought up a very good point, and we struggle at Kidney Cancer Canada with this every day, and I'm sure that urologists do too, because not everybody is able to access the same, not all urologists are able to access the same information, like some in remote and rural areas, they might only see one kidney cancer case, in a span of years. So it's really difficult to get the same information out to everybody, but they mentioned that they wish that they could get this into the urologist's offices and also the family physicians, because sometimes they're the advocates for the patients as well. So we're always going to ask you doctors how we can do it better.
But I think I agree. I think that's the role of Kidney Cancer Canada, to advocate for their patient. But I think it's also the role of the patient themselves to seek out, if they're not comfortable, if they feel like their urologist is not on par with the evidence. I think it's definitely possible to ask for referrals elsewhere, and I think there's nothing wrong with that, right? It's your health.
Thank you for that reassurance. We appreciate it. And on that note, we're going to say thank you so much. This has been so interesting. If you have a serious question that you would like answered, please send it to Mona and I at info@kidneycancercanada.ca. We will reach out to Dr. Richard and try and get an answer back to you. Not personal cases, please. We try and avoid that situation, but if you have a general question about the information that's been offered tonight, please send it in to us and we'll do our best to get you an answer. I can't thank you enough, Dr. Richard. It's been so great information. We'll look forward to having this on our website for our patient community to refer to. So
thank you very much for the invitation, and thank you for everything you're doing for our patient. Thank you very much.
Thank you. Take care and have a great evening, everyone.
Have a great evening. Bye. Thank you.
Bye-bye. Thank you.